What's up, guys? Welcome to the episode on Pitocin after delivery. Look, I think in this episode, I did tell the story at the end, but I'll just tell it real quick before we start. I went into so I was at the hospital and the doctor gave me the order. So this mom came in. I'm getting ahead of myself. It's her fifth baby. She came in 4 centimeters with contractions. And she said, once her water breaks, she tends to go fast. So in triage, before she had a bed, the doctor decided with her to break her water, move things along quicker. She was contracting, but they were manageable, and they weren't quite sure she was in active labor or could get admitted like that. So when she didn't want to go home, she was too uncomfortable. The contractions were still strong, maybe not close together enough for us to want to keep her there. So she agreed to rupture her bag, because she knows she goes quickly after that. And so they broke her bag. It still took another 2 hours to get her into a room. I highly recommend you wait until you get into a room. You say, okay, I have no problem. Whatever. It is what it is. We had a room for her, so I guess that's besides the point. We got her into a room. I don't know why it took 2 hours. I think, it wasn't the room, it was the nurses. We didn't have a nurse for her. So I had delivered my patient and I was able to take a new patient. So they finally moved her into the room and then I got her. And yeah, she'd been ruptured for, I think, an hour or two at that point. She was feeling super uncomfortable when I went in there. And I said, okay, well, let me watch the baby for a little bit, take some vital signs. And if you want to walk around, yeah, everything looked great. I said, she told me that her contractions were feeling so much stronger with the water breaking. And that was it. Then I said, okay, great. So I go outside to the nurse's station, and I think it was a resident. She had seen the doctor that ruptured her bag. And she said, hey, the doctor said that you can go ahead and start Oxytocin now, like as soon as you're ready. And I just looked at her like, what? This is how they do it. You guys, they'll break your bag and start you on Pitocin. I am getting these orders for Pitocin earlier and earlier. Like they want to break your water and get you on Pitocin in triage. Like they're not waiting. They said, let's get this going. We have a room for you. Let's break your water and get you on Pitocin. What is it? What's the deal? Can someone tell me? Is anyone out there that can tell me what, if they notice this too? Is it just me? Are we just like, we're not going to watch natural labor at all? These are women that are coming in labor, right? But we're not really sending them home, or they don't want to go home, but we're not watching to see if they're changing on their own. We're just breaking their water. That keeps them there. And they're starting Pitocin because they broke their water. And because they broke their water, they're at risk for infection is what they want to immediately say after they break their water. Okay. Yeah. And so they want to, okay, so we need to get this moving because your water broke. Yeah, but you broke it. Oh, okay. And just none of it makes sense. So they want to add a little bit Pitocin right away. I would probably prefer maybe adding a little Pitocin and seeing if that jumpstarts things to their approval before breaking the water. But that's my own personal opinion. A lot of women, like this patient, it makes sense. She said, I go faster when you break my water. Okay, let's start with that. But then to just immediately after that start Pitocin, I was like, okay, well, let me go back in there. And I think I made a stink face or something, because the doctor's like, if you have a problem with that, like, we could talk. And of course, like, I'll talk. We could talk. I've barely talked to the lady. Let me see what's going on. She told me her contractions were getting stronger. So let's go check. I went in there and I asked them, and then this is what I got to at the end of this episode, but they didn't even know what Pitocin was. They're like, what is that word? I've never heard that word. So understand that if you are going to get Pitocin, you need to give an informed consent to anything that you're doing, but especially a drug, a medication. So when your nurse is coming in, she shouldn't be the first one that you hear the word Pitocin, right? So I had to do education. When I do education, I am not steering you in one way or the other. This is your choice. I can give you the doctor's recommendation. I can even give you my opinion recommendation, but honestly, I don't want to influence you that much. I think the education and the facts and the data that we have are enough, right? If I give it to you straight, that's enough for you to make the decision that's best for you. If you have the risks, if you have the benefits, if you have your alternate options. So, yeah, she didn't even know what it was. So I'm seeing this too many times. Every shift I'm dealing with this these days. And I'm doing a lot more education than normal. And they're intervening sooner and sooner. So I'm just going to get on my soapbox now before we get started. But this is what I just want you to know is the word Pitocin. I want you to know this drug. This is the most used drug in labor and delivery. This is like our holy grail of intervention is Pitocin. I just got to tell you. So understand it, appreciate it for what it can do. I'm thankful for it for many, but it is not a medication that's needed for everybody. Women aren't like, oh, you're pregnant, oh, you're in labor. Okay, here's your prescription for Pitocin. But no. Everything has its place. All right. Just make sure that you're educated on it and that you know if you need it or not. One thing that we do not do very often is tell you that we're giving it to you right after birth. And your choice between an expectant management and an active management, if we're going to give Pitocin, if we're going to do all the things, is also not really discussed or given to you. We just say, get on your back, deliver your baby, and then they do what they need to do. And you're like, thank you for my baby. But what are they doing? What are they doing to you? Do you have any clue? That's why labor and birth, I didn't just like when I was 20, I had no idea. And that's why it can feel like the birth is being done to you. Like you're in critical care. You were just in an accident and now you just gave birth and we're doing all these things to you like you just got injured. But that's not what birth is unless things are going wrong. Then we have to jump in. And unfortunately, so many of the things that we do in the hospital to prevent things from going wrong cause things to go wrong. And then we're trying to fix it. And you're like, oh my God, thank you for saving me. I'm like, yeah, you wouldn't even need saving if we didn't butt in, but it's truth. It's the truth. So be part of that team, be part of that decision and that management and the discussion. And I probably say it like 3 times in this episode, but please listen in. I want you to know this. We're going to talk about Pitocin and its use in postpartum, that time period, that right after delivery, right after, during the 3rd stage of birth, when you're delivering your placenta and afterwards. That's what I want to talk about because it's never talked about. Most of my friends, they text me like, did I get Oxytocin? Did I get Pitocin after I delivered? I don't think so. I'm like, most likely 1,000%, because if you don't want it, it's usually has to be a discussion. And it usually has to be a discussion that you bring up. All right. I'm not going to waste any more time. I never like these long intros, but I just had to tell you that story real quick. I'll repeat it just a little bit at the end, but I hope you enjoy everything postpartum Pitocin and the history of it. How did it even come to be? Let's get into it. Welcome to the Birthling Podcast, presented by My Friend's a Nurse. I am your host, Colette Colliker, a high-risk labor and delivery nurse right here in sunny California. I'm also an OB certified specialist, birth educator, lactation expert, and mother of 2 beautiful daughters. I am passionate about guiding you through the miraculous journey of pregnancy and childbirth, using evidence and history and asking the reason why. I have some incredible medical friends and colleagues, and we're all here to help you navigate this often overwhelming birthing hospital system in the United States. My goal is to gain trust in birth, improve this system, and provide some valuable insights. Let's make this journey a little less daunting and a lot more joyful. Let's get into it. I want to get into Pitocin today, specifically postpartum Pitocin and how we use it and why we use it, what the evidence shows, and of course, the history behind it. We can't talk about Pitocin without talking about hemorrhaging. So just a trigger warning, I will be discussing bleeding after birth, its significance, and the main reason why I believe we are giving Pitocin now, right? That's the main reason is to decrease hemorrhaging. And if you don't want to hear about this, then you're probably not my client because we got to talk about this stuff, but no problem. Just see you at the next episode when we have our wonderful interview. But for today, we are going to talk about Pitocin and hemorrhaging and placenta, delivering your placenta. These are all part of that first 15. We delivered our baby. Next stage is the third stage of labor, and that's delivering our placenta. And during that time, or directly right after, you have the risk of hemorrhaging. You actually have a risk of hemorrhaging for months after birth. Okay, so don't think just because you're in postpartum or you're home that you are all in the clear. You need to know the signs to look out for. And we'll discuss those signs maybe another episode, a different time. It's not part of the first 15. So let's keep it at hemorrhaging at the first 15 or even in the first hour when you're with your nurse and she's checking your belly, she's checking the fundus to make sure that you're not bleeding too much, that you don't have clots, and that your uterus is nice and tight. So that's what it's all about, is your uterus being nice and tight, right? Bleeding at birth, and we're going to get into it right now, bleeding at birth, hemorrhaging is the major reason, it's the number one reason that mothers die during birth, right? So, and it's usually a lack of acknowledgement, assessment, action from the medical team, or if they're not in the hospital, maybe they're just, I guess lack of action to take care of it, because there are things that we can do most of the time to catch it early and quick. And if we act quickly, we can stop it and do what we need to do to make sure that you're okay. The ones that die is usually there's just an issue that either is completely out of control or we just didn't catch it in time at all. It is rare in the hospital if it's looked at with the amount of birth that we have. But in the United States, it's still way too high. So, and we're doing our best to resolve these things with our assessments, with a standardization. Yes, the standards. See if I can talk today. Of our care, of our assessments. So checking your fundus every 15 minutes and making sure it's nice and firm, checking your pad. Is your nurse actually lifting the sheet up and looking between your legs at that pad? If she's not, I need to go sometimes open up those legs and look underneath because the blood can pool under your booty. And if she's not looking properly, she'll miss it. And that's not what you want. So you need to advocate, just because, especially if you're saying, I feel a little blood and they're not really looking. No, you could ask for another nurse to come double check, or you can have your husband look if he's up for it, or if you have a doula for sure. You should, unfortunately, you may have to advocate for yourself and push for those assessments, but we usually normally check every 15 minutes. We're checking your blood pressure, your pulse, and making sure that there's no signs of bleeding, hemorrhaging, either maybe from a laceration or a tear that wasn't properly fixed. Maybe it's a cervical tear. Maybe the uterus, which is the most common, is not contracting, right? And this has been the issue. This has been a problem, hemorrhaging at birth, throughout time, throughout history. And it doesn't matter which country, everywhere. This is a big issue because there's such an increased blood flow to the placenta, to the uterus. And if it's not properly cut off after birth, it's going to keep supplying, right? The first accounts of hemorrhaging at birth was in the 1st century by Soranus of Ephesus. Saying that right, I have it written down here. Soranus of Ephesus, probably Greek or Roman. I don't know. I didn't look that far into it, but he put down the actual management, how they took care of it back in the 1st century. It was limited to lying down in a little dark, cool room on a hard surface and elevating the legs. So that kind of makes sense, right? We want it to be nice and cool. And maybe the hard surface was the coolest place to be on and nice and flat. That way their legs can be in the air and you're causing all the blood and what you're doing with the cold is to constrict the blood vessels, the surrounding blood vessels. And then when your legs are in the air, all the blood will be going to your brain and to your vital organs, not hanging out in your legs. So it makes sense. It probably also increased the bleeding if they didn't take care of it. He even described bandaging the legs up when they're up, like so nice and tight to keep blood away from the legs and keep the blood where it's needed. So it was pretty interesting to see how they tried to take care of this before, right? We call a uterus that isn't contracted, and they need to contract, right? And we'll talk about that why. But when it's soft after delivery, when it's kind of mushy, when it doesn't feel like a nice contracted muscle, then that accounts for 80 to 85% of hemorrhages. We call that uterine atony, ATONY, when it's soft. We also call it boggy. You may hear those words. So now you know the inside terms. Boggy and atony is when the uterus is soft, it's not contracting. And that's what we're checking for when we push down in your belly a little bit. We're looking for the top of the uterus to see if it's boggy or firm. Once that placenta, so third stage, once the placenta separates from the uterine wall, it leaves a very vascular area that I was talking about. This is where all the blood vessels were torn away as it was released, and those crisscross of blood vessels are arranged in a way that a firm contraction of the uterus, and it doesn't release. Like when you're in labor, it contracts and releases. We want it to just contract and not release anymore. And those muscle fibers around that contraction, when they're contracted, they're actually going to constrict the blood vessels to prevent too much bleeding. So knowing this process and ability early on, as early as like 1500 BC, they were able to start using things to increase that contraction because they're like, okay, now we understand the placenta leaves and then all these blood vessels, if it's not contracted and constricting them, then they're just going to keep supplying blood. And instead of going to the baby, it's just going to go directly into the uterus, this empty uterus, and it's going to come out of the vagina and we're going to see it pooling under her. Not something pretty, and I can understand their methods before, but once they realized why, they wanted to start finding things to use to contract it. They use things like hemp and honey, celery and milk, and juniper berries. Like they also use like a fly excrement. They try anything, see what works. And I guess a few of those worked, maybe. I don't know about the celery and milk. Got to look into those specifically. Didn't have time yet, but interesting. Anyways, they tossed them, so they probably weren't that good. But they did find something that did work after all those trials and errors. In the 17th century, the first effective oxytocin drug. When they say oxytocin, it's like a contraction drug. It's a type of drug, whether it's from plants or it's from medicine, synthetic, doesn't matter, that will contract your uterus, just like oxytocin. So this oxytocin drug that they found was called ergo or ergot. I don't know yet how to pronounce it. If anyone wants to let me know. Ergot, ERGOT. Who knows? I don't know. But that's actually from a fungus that grew on the ears of cereal grains, and particularly rye. And eating that fungus would actually make people super sick. So they didn't want people to actually eat it because they would just be throwing up and nauseous and all of these things. And they noticed that sometimes, it would get everywhere. People would eat it. They couldn't clean it well enough. And there would be like an epidemic of this fungal infection. Everyone was getting it. Pregnant women, though, would miscarry. They were noticing like when everyone got sick with this fungus, this ergot, women would be miscarrying. And finally, midwives were the ones that were like, what is going on? It must be this fungus. It must be this. All the women that are getting sick are miscarrying. What's happening? And it's because the fungus was causing uterine contractions. And of course, you don't want a uterus to just clamp down like that when you're pregnant. The baby can't handle it and you'll deliver. So they were miscarrying. But then they realized, well, Argo, this is it. We can use this to contract the uterus like we want after delivery. So especially when women that are not contracting right away or enough and they were hemorrhaging. So they would grind the fungus into a powder and used it a lot. They were using a lot midwives in Germany, and it went into a book in 1582. It's a book of herbs. And in 1787, it was noted that all were reassured. Like, don't you worry. They love reassuring everyone. Don't worry. It's going to make labor quicker and more powerful than anything else. So they're like, look, we could give you a little bit and it's going to make a powerful and very fast labor. So they wanted to use it in labor as well. It was brought to the U.S., as most things were, in 1808 by Dr. John Stearns. He noticed that it was super effective, but also that the pain of labor were particularly forcing. That's a quote. Particularly forcing. Very strong with this medication. But it definitely worked to speed up the delivery, and he also found it to be super unpredictable. And it did result in really strong or long contractions, and that actually led to babies dying and even the uterus rupturing. The same kind of things we are a little cautious of when we give Pitocin right nowadays. Same thing back then, but they didn't have the best way. It was a lot of trial error to find out how much is too much and how do we monitor it. What's the benefit versus risk of having a fast delivery? And so it became more common, though, because of that, to just give it after the baby was born, right? And that prevented the uterine atony and would help pinch off those blood vessels when a uterus wasn't contracting properly. Of course, 19th century and early 20th century, a lot going on in the OB world during that time. Science was here and they were able to analyze ergo. I hope I'm saying that right. It sounds fancy that way. And they were able to study it and find out what actually made it work. And so it's these alkaloids called ergotoxin and ergotamine. Those two became the standard drug of choice. So they found out what's actually working in this fungus. They pulled it out and they made medication from it. Bravo. And so that was the drug that they would give for postpartum hemorrhage. In 1932, they figured out how to use the ergo in water. So it was water soluble. And so that was awesome because a few years later, 1935, they created this drug called ergometrine. And by 1940, they began to advocate it as part of that active management that we spoke about in the last few episodes. If you heard about clamping the cord, especially immediately back then, and delivering the placenta quickly by traction, and Pitocin, but we didn't have Pitocin then. So they were giving the ergometrine back then. So 0.2 milligrams of ergometrine went through the IV at the birth of the baby. So this was by 1940. By the 1950s, routine active management with the medication showed to decrease hemorrhage by 40%. Bingo, they did it. They're helping so many women after birth by just actively managing it for everybody. So everybody, it doesn't matter about the risks or what's going on. We're just going to routinely do this for everyone. It's been a while, you guys. This is what, like 80 years in 1950. Okay. 70 years that we've been doing this, right? 76 years to be exact, 75. Anyways, it's been in a long time that we are doing this active management. Things are changing slowly. We're not clamping the cord now immediately, but we are still giving medication after birth, right? This is where it started. A little earlier than that, in 1906, Sir Henry Dale. So this is kind of like parallel, right? That they're giving the ergometrine. This Sir Henry Dale of London, he found an extract from a human pituitary gland. And at the base of the brain, that's where our pituitary gland is. And he found that this extract, it caused uterine contractions in a pregnant cat. So he gave it to the OB William Blair Bell. If you've heard of him, I don't know. He founded the Royal College of Obstetricians and Gynecologists. Woohoo! I didn't know him either. Don't worry. But they published this new extract. They said it was a hormone in the clinical practice in 1909. So turn of the century, they found Pitocin. They found Oxytocin, actually, not Pitocin yet. Oxytocin, the actual stuff in our pituitary gland that causes contractions. By 1928, the chemists were able to separate the oxytocin into two items. It was either oxytocic, the Pitocin, so that's the one that caused the uterine contractions, and vasopressin. And then if you know that one is the one that causes our blood vessels to constrict, great for high blood pressures, or relax, sorry. Is it constrict? Constrict. So now we knew it was a bit safer because they took out a little bit of that blood pressure fluctuating issues when they used to give, or when they tried it out. So now they don't have to worry about the blood pressure dropping, but they can use it for contractions. There was another chemist, Vincent du Vineau, and I think we spoke about him earlier too. No. But this guy won the Nobel Prize for chemistry for his discovery of the actual two separate oxytocin and the vasopressin. So Pitocin, then, I say Pitocin, right, is the synthetic form of oxytocin. It's commonly used in clinical practice today to start or induce or even speed up. When you're in labor, we want to speed it up. We call that augmentation. We want to augment your labor, speed it up. So if we want to induce or we want to augment it, we like to use a little bit of this synthetic oxytocin that we call Pitocin. Pitocin is a brand name, so it's different in other countries. Oxytocin is the generic name, synthetic oxytocin. So it's going to help us speed up, but it's also going to help contract after birth during active management. After the delivery of the baby, usually of the shoulder, they are going to give you a dose of this Pitocin or oxytocin to contract that uterus and expel the placenta right away and clamp down on those blood vessels, right? Speeding it up. They don't like a long, drawn out third stage of labor. The placenta is hanging out there, right? So that placenta usually delivers in just a few minutes with this active management. Usually, because of that, that alone could increase the risk of hemorrhaging. So then they throw Pitocin on top of it and clamp it down, and they fix the problem. They're just fixing their problems with more interventions and problems, if you ask me. But whatever, for most women, it does a great job. The actual name, the actual word oxytocin, is Greek for quick birth. Did you know that? Yeah. So quick timeline. Let's just review what we just went through so we understand the history. In the 1950s, synthetic oxytocin was available for use. 1953 and 54, Sir Vincent du Vineau is a PhD. He achieved the synthesis of oxytocin and he published it as this chemical structure. Bravo. He got the Nobel Peace Prize in 1955 in biochemistry. And by the way, the research on that in the 1950s was done with extracts from cow and pig pituitary glands. So, they weren't practicing on humans. In the 1960s, it became included in active management of the third stage of labor. So it only took about 20 years from using ergometrine to Pitocin. So 1940s, 1950 they started, and then 1960s, they're like, this is even better. Oxytocin works even better. So they use it with active management along with the cord clamping and controlled cord traction. And it was all meant to prevent postpartum hemorrhage. Today, commercially sold oxytocin is prepared synthetically in laboratories, just so you know. So it's all synthetic. There's no pig or no animals involved anymore. Thank you, animals that helped us, but we're not doing that anymore. So it's all synthetic, right? So unfortunately, so during that time that they were using the ergometrine or ergo, they made some mistakes. So, right, they used it too strong during labor. So they unfortunately made the same mistakes with oxytocin, the ones that made the uterine contractions too strong. So while they were trying to find these doses, they were causing heavy labor, a lot of pain, fetal asphyxia. So baby wasn't able to breathe because it was tightening around the umbilical cord too much. And then also uterine ruptures. So, oops. So they had to test that out on a lot of women in those times. But in that time, 1950s and 60s, they still thought it was better than nothing and were using it. They were saving, they believed, a lot of women from hemorrhaging. What did I say? 40%. And they used it in the management of postpartum hemorrhage. So they would give it as well. Maybe they didn't give it before, but they definitely gave it when the woman was hemorrhaging. About 40 years ago, in the 1980s, they had several randomized control trials and subsequent meta-analysis that confirmed the effectiveness of active management of the third stage of labor to reduce blood loss, reduce postpartum hemorrhage, and higher therapeutic doses of oxytocin drugs and the need for a blood transfusion. Okay, so it reduced all those things. It reduced the blood loss. It reduced the need for using oxytocin as to fix it. They just use it to prevent it. So yeah. And it reduced the need for a blood transfusion. It also actually reduces the need for acute uterine inversion. So from the placenta, except for the uterus going inside out. What? I didn't even know that. I learned things on these episodes. You'd be surprised. So they were both, the ergometrine and the oxytocin were both effective, but the oxytocin has become the drug of first choice. It was a little bit more effective, less side effects, more controlled. So interesting stuff. That's the history of that. What other things were you, so alternates to these two medications, especially Pitocin? Well, we studied prostaglandins. These were substances, talking too fast. I used to talk nice and slow. They were released. These are stuff that are released from a prostate and is found in semen. So prostaglandins, prostate, we get it. They were found to also cause uterine contractions. That's why when moms want to go into labor, I was like, well, yeah, do the deed. And if he can, come inside you, sorry to be so vulgar. Won't let me type that out, but yeah, his semen has these prostaglandins in it. I don't know what extent or if it could do anything, but those are the same things that we give you when we're going to induce you. Do you know that? Cytotec, misoprostol. We found that in 1990. Earlier than that, we found this expensive stuff called Hemabate, carboprost. I call it Hemabate. And that we found in 1970. So that we created that from the substance, the semen that we found, the prostaglandins in the prostate. So they created that one first. It does have a side effect, and we still use it in the hospital today, the Hemabate, but it does have a side effect of some diarrhea and some GI looseness. So you'll see most providers not prescribe that one. That'll be like last resort, honestly. And we'll go straight to the misoprostol, the Cytotec. We found that in the 1990s. It's very cheap. It was most stable, and it was easiest to store. So it became very popular. It's a very popular oxytocin kind of drug that creates contractions. We used it. They always say off-label. They did create it to contract that uterus for postpartum hemorrhage, but we do use it to get your labor started by working on the cervix itself. It starts to, I won't really get into inductions or what it does on the cervix, but it does ripen it. So we do use that in the hospital, and then it will cause contractions as well. So it was very popular, especially in developing countries, because it was cheap, it was effective, and easy to store. It held for a long time. So yeah, they used it in those countries where 99% of the maternal deaths due to postpartum hemorrhage occur. It's these countries that don't have Pitocin. They can't get these other drugs. They don't have these abilities that we have, and I'm so thankful for. But unfortunately, we even to this day, we still don't know exactly, especially in the 1990s. But even now, we're still working on what is the most effective route and the dose and all of that. We're still kind of working that out. But for the most part, we figured it out. So that is your alternatives, is those prostaglandins. We give also Hemorrhaging. That's an injection that we'll give you right away if we feel that we need to contract that uterus. TXA, that's another IV medication and fluid that we give. So we have multiple, but our first line of defense is oxytocin, and we give that prophylactically. We give it first to prevent it. So just be aware of that. Discuss with your doctor. When you speak with your doctor, you want to ask them, how do you usually manage the third stage? Is it active or expectant? Are you just going to watch and see how my body works? And if it contracts and everything goes as it should, and then I don't need that extra medication. And then you treat me if I do hemorrhage, or are you going to work things down there and give me medication, the oxytocin right away, and pull traction on the cord and do all the things? What do you normally do? That's a conversation that you need to have with your doctor, right? For your doctors nowadays, the ACOG and even the American Academy of Family Physicians, because you may have a family practice physician, they recommend using Pitocin for active management of the third stage of labor. This is to reduce the postpartum hemorrhage. The World Health Association organization, WHO recommends administering 10 international units, those are what we call 10 IUs of oxytocin, IV or intramuscularly, so in an injection in your thigh or in your arm, to prevent postpartum hemorrhage. So it's all preventative, they all recommend. If the mom already has an IV, the WHO definitely recommends giving it through the IV. And if a hemorrhage continues after oxytocin, then they recommend going to the second line of uterotonics. So uterotonics are medications that cause uterine contractions as well, another name for it. That's the Hemorrhaging, the ergometrine, misoprostol, prostaglandin analogs, or TXA. So the question then, again, is to your providers how they're going to manage that stage. What is their preference? You need to decide between the active management and expectant management. It may be helpful to discuss the risk factors for blood loss, like what is my personal risk of bleeding after birth. If it's high, then you may want to have this active management. If they're showing signs, prevent anything. Or maybe just watch and see. If you're very low risk, you've never had a postpartum hemorrhage before, whatever the case, you're not having a big baby, you're twins, you're not on Pitocin, discuss what are the risk factors. I'm not going to go into it today, but maybe I guess I did a little bit already, right? So if your uterus has been stretched out during labor and pregnancy, so you have a big baby or twins or triplets, if you have high blood pressure already, preeclampsia, if you have diabetes, if you have a long labor, your uterus has been contracting for a long time, and maybe it's tired after it delivers, for lack of a better word. Have you been on oxytocin throughout your labor? How are the receptors on there? Is this just overfilled? Sometimes if you give a lot of Pitocin during labor, then Pitocin after labor is less effective. Did you know that? Other risk factors, discuss with your doctor, okay? But these are just a few. Depending on your doctor, because they all have their different opinions and ideas and practice, and how they follow their guidelines and recommendations through ACOG, they'll most likely participate in this active management. This is what I see in labor. This is what I see in the birth room most of the time. Most of the time is also not a conversation with the mom or the dad or the mom. It's just not a conversation whatsoever. And I hope we can change that. I want you safe. I do not want you to have a postpartum hemorrhage, but it's still a medication. It's still an intervention that we can do when it's not an emergency. I understand when it's an emergency, we have to jump in and there's going to be less conversation, but we're doing so many things. We're making so many decisions for you when it's not an emergency, and you should really be part of this conversation. And that's what I'm trying to change. That's what I'm trying to educate and coach my clients through, to be able to ask those questions and speak up, to change the direction your birth can go in when it's in a medical hands that you may not align with, and they may not have your best interests at heart. They want you to stay alive. They want you safe. They definitely don't want to end up, with any complications, but they also maybe want to go home. They have to get back to their clinic. Things get rushed a lot, and these conversations get left out. And then sometimes these interventions cause more problems than they were trying to prevent. I see it so much. So you should really need to have a say when it comes to this stuff. All right. So let's see what else. So the controlled traction I talked about, that's part of it, right? If you're not familiar, that is basically to help deliver the placenta, right? So it separates from the uterine wall. They're tugging on it, causing a little traction, not to pull the placenta away from the wall. They're not trying to do that whatsoever, but they are trying to kind of guide it away. One, they'll be able to see, it's not attached anymore. So now they know the placenta was detached, and they can guide the placenta out, especially if you're laying flat on your back. I think we spoke about that during the cord clamping episode. So if you're laying flat on your back, your placenta, if the uterus contracts around it, it's going to could be stuck inside there. So the uterus is not going to be able to clamp around it tight enough, and will cause uterine atony. The placenta is not it. That also happens if there's clots inside of the uterus. So if anything is left behind in a uterus, whether it's the placenta or clots or maybe a piece of the placenta, whatever's there, the uterus can't contract around it, and they need to deliver it. So the traction is more to guide that placenta out as quick as possible so that they can control that bleeding right away. It all makes sense to me, and personally, I got it. I was totally for it. No problem trying to prevent that. I also had an epidural, so I didn't feel any of the added cramping. Maybe later I did, but I had it for both of my babies, so I personally can't tell you if it is excessively more painful to have the Pitocin or the natural cramping. So I'm sorry I can't tell you that. But that it could potentially definitely make it more uncomfortable having Pitocin or Oxytocin given to you instead of naturally contracting. Okay, so we know that, but the evidence. So it says that the evidence is still out on the cord traction. So I was discussing, I went off a tangent as I do, but the traction, they do that, but it's basically to guide it out. And they haven't done the work. The data isn't out yet if doing that actually helps prevent hemorrhaging. It's just kind of a step that they do because you're laying flat on your back. If you stood up, a placenta would probably fall out. So that's okay. I just want to make sure that you know when they do the traction, they're not actually pulling it, but they could accidentally pull too hard, right? And then that could prematurely separate the placenta, causing it to tear a little bit and leave a piece of placenta inside. So 2 of the other things that we would do to manage hemorrhaging is empty your bladder. We want to make sure your bladder isn't full, because a big bladder pushing on the uterus also prevents it from contracting effectively. And we want to make sure with an ultrasound that there's no little piece of placenta left in there or large clots that are in there. So the next thing I would do we empty the bladder, and then we get an ultrasound to just double check, make sure all of the placenta was out. The doctor definitely wants to take a look at the placenta itself, especially the part that was attached to the mom, and make sure there's no pieces missing, little chunks bitten out. And that would be a reason. But because we want to do all of these things to help prevent, but then if you are hemorrhaging and there's a reason, we need to figure out what it is. If it's a tear or a laceration inside, they need to repair that. Okay, so lots of things that we would do if you hemorrhage, and then things we do to prevent it. All right. When it comes to the medical opinion, usually they will value the risk, right? Whatever it is for you. Above that of your increased pain or your feeding and bonding. So that's why it should be discussed, the risk for bleeding with you, right? Is it low? Is your risk low? Do you prefer minimal interventions unless medically necessary? That's something that could be on your birth plan, right? Okay with postpartum Pitocin. Would like to avoid postpartum Pitocin and interventions unless medically necessary. So put that in your birth plan, discuss it with your doctors, right? Listen, let's discuss real quick why we're doing all of this. I just want it to sink in. I'm going to end it off with this, right? Every year in the United States, we lose 700 women to pregnancy-related complications with obstetric hemorrhage, accounting for 70 to 80% of that. Okay, so too many women, 600 plus women passing away, dying in birth, not able to raise their babies because they bled. So active management is so common that it often fails to be discussed with women and their partners and their family. Along with active management, your nurse will assess the top of your uterus every 15 minutes for 2 hours to make sure that it is contracted and firm, along with checking your pad. I'm just reiterating all of this for you guys, a little summary. They're going to check for the incision if you tore, make sure that that it was repaired properly, and they're going to check your bladder location, make sure that it's not full. We're going to check your blood pressure, your pulse, your level of consciousness, your pain, and we're going to do that routinely. So every 15 minutes. You got to get on your nurse if she's not. Right? You have to take responsibility for your own birth and your baby and your life. So there's no consensus on dosing or timing of administration with Pitocin, but most of the time we give 10 to 40 units, and we give it in a bag, and we give it real fast. 10 units in an injection or 10 units in a bag. We usually give 3 over 3 minutes, boom, real quick, and then we put you on a drip, right? We have these standardized sets in the hospital to prevent doctors from just doing things subjectively or on a whim or trying out new ideas or theories. We don't want any of that in the hospital. So it's all pretty standardized what we're going to give you. This ensures safety and high quality care on our part. That doesn't mean it's a policy. That doesn't mean we need to force you to have it. We do see what happens to women that don't have it. So maybe we're pushier or more authoritative when it comes to doing these things to you, or even doing it without you being involved. And that needs to change. I'm going to get off my high horse, right? I use evidence from Evidence-Based Birth. If you know them, I went through ACOG, A1. So I highly recommend Evidence-Based Birth if you need, but understand that education like that is going to give you the outside sources. But what does the evidence of your body, your history, your needs, your values say? You have to bring that into account when you're speaking with your provider and you're coming up with a plan. All right. I hope you enjoyed this episode on Pitocin postpartum. Maybe one day we'll get into more about Pitocin during induction and augmentation. But I just wanted you to know the history of it, why we do it, because it's just not said. I can't have these conversations very well in the birth room. I can do a quick explanation and let them know before, and I'm a rare case. Most of the time, they don't. The doctors won't tell you. No one will tell you. I went in and I asked, I got an order for Pitocin, and I went into the room to ask them about the parents about it. And they said, I've never heard that word before. I was like, what? One, this was her 5th kid. And 2, why am I in here about to give a medication to you that you've never heard of? So no conversation with the doctor was had. And this is for an augmentation. So I'm over it. So we have to do better. We have to do better. So I'm glad you're here and listened. Send me any questions to my email, Colette@myfriendsandnurse.com, or find me on Instagram and DM me. I'm always in there. And I look forward to hearing from you. And I'll see you next week. Okay, bye. Real quick before you go, I want to just let you know about next week's episode. We're going to be talking to Rachel Cappuccino. She is a physical therapist, pelvic floor specialist. She actually lives in my community and works with the same birth workers that I speak with. And she's kind of helping introduce me to the community as I grow my business. And I've just appreciated speaking with her and getting to know her. I look up to her just as a business owner and woman and mother, and what she does for our women and why. So we get into that story with Rachel next week. So make sure you join us and get some more tips and tricks on protecting your pelvic floor, preventing tears, and pushing correctly. We can't hear enough about this. So I'll see you then. Have a great week. Thank you for listening to My Friends and Nurse presents the Birthling Podcast. We hope you enjoyed today's episode and found it valuable. Before we go, a quick reminder. The information shared on this podcast is for educational purposes only and should not be considered medical advice. Always consult with your healthcare provider for any medical concerns or questions. If you enjoyed the episode, please subscribe, leave a review, and share it with your friends. Your support helps us reach more people and continue to bring you great content. Until next time, stay healthy and stay informed.